In this video we discuss tips for surgery in severe vitreomacular traction with foveoschisis. In this video, shared by Dr. Agustín Magnetto from Buenos Aires, Argentina, we discuss a case of a patient who underwent pars plana vitrectomy and peeling due to vitreoretinal traction. At the beginning of the surgery, one can notice the typical sheen of a thickened posterior hyaloid seen in these cases. The surgeon injects intravitreal triamcinolone to facilitate visualization. Because the thickness of the hyaloid makes access to posterior planes difficult, the surgeon uses a pick to create a small opening. Next, in this same spot, he introduces the vitrectomy probe with high cut rates and low vacuum, generating controlled and effective traction to remove the hyaloid. When initiating the posterior vitreous detachment, it is possible to observe significant traction over the fovea, with risk of tissue damage. Therefore, the surgeon first isolates the central hyaloid and releases the vitreous 360 degrees around the fovea, without engaging vacuum and moving within the same plane. After isolating, he performs the typical maneuver for detaching the posterior hyaloid, taking care to avoid possible peripheral iatrogenic breaks. The adhesions along the vascular arcades are firm and usually require very controlled movements at this stage. With the vitreous detached, he performs a complete vitrectomy with shaving of the vitreous base and finishes with an internal limiting membrane peel after staining with brilliant blue dye. Ideally, it is important to preserve the internal limiting membrane over the fovea in these cases, to avoid damage to the center of the macula. At the end, the OCT shows residual foveoschisis, without areas of traction, with a tendency to improve over time.